first of all, a big thank to the INASL leadership and to Dr. Dusaja for welcoming ILTS to INASL, and this is our first year presence here, and I am extremely grateful for building this bridge and welcoming INASL to ILTS, hopefully in Singapore next year. Also, as I mentioned yesterday, we are very thrilled to start the Southeast Asian, South Asian chapter of ILTS, and really hopeful that I can see all of you as part of this chapter and working together to toward the progression of liver transplantation in this area. And I also want to particularly thank Dr. Prashant Bangi, who is here, who was extremely helpful and tremendous in helping to set up this chapter and moving it forward, and extremely thankful. So saying that, I will stay away from MET-ALD because it's very complex, and talking about multidisciplinary approach for the treatment of that is really going beyond what is the topic, and I just will focus on ALD and the multidisciplinary approach for managing this patient post-transplant. These are my conflict of interest. There is no concern, no, at least no conflict related to this presentation. So until a few years ago, patient with the alcohol-related liver disease has to wait, at least in my center and many centers around the world, for 6 months to be considered for transplant. However, we all know that the outcome of patients with, that have been transplanted for alcohol-related liver disease has been excellent, and even those who have been transplanted with less than 6 months abstinence, they generally have a very good outcome in terms of patient and graft survival. And even studies that have focused only on more severe form or acute alcoholic hepatitis, a summary of these studies are on these slides, generally have shown a very good outcome in terms of post-transplant survival compared to alcohol-associated liver disease with cirrhosis, decompensation, and transplantation. What is of a concern is usually post-transplant relapse, and that's where the issues raised mainly in terms of what is the definition of relapse, how much relapse are we accepting, and what is really the rate of relapse post-transplant. And the definition, as we all know in the literature, is very muddy because the studies are mainly retrospective, pulling together all kind of definition of relapse. But what we know is a wide range of 15 to 50% range of relapse post-transplant. And when we look particularly at those newer studies that have focus on transplanting patients without that period of 6 months abstinence, and that's the study, this important study, the Accelerate study, which is a multi-center study from the US. When they looked at the pattern of relapse to alcohol with longer period of follow-up, they have shown that those patients who have an early and heavy relapse to alcohol, or early but not necessarily even heavy, they have at 5 years shorter projection of survival as low as 53% after transplant. And again, another most recent publication that have pulled all the data from all the studies together report a range of 25 to 30% rate of relapse for severe alcoholic hepatitis patient compared to decompensated liver disease. All this study basically raising the alarm that transplanting this patient is feasible, the graft and patient survival is outcome. However, we can deal with we may face a high rate of relapse and potentially long-term loss of graft if there is nothing else set in place to avoid that. Which raised the question that, like many of us hepatologists in this room, when we see any patient with alcohol-related liver disease, the question that we are asking is, will this patient drink again? If I had a magic ball and have it in my hand, would the crystal tell me this patient will drink? And also, probably most importantly, the question is this patient at high risk of poor post-transplant outcome due to return to problematic alcohol use? And what can we do to help mitigate this risk? And that's what we had in mind when, in 2018 in Toronto, when we decided to move from the 6 months abstinence and instead have more a holistic approach to transplanting patients with alcohol-related liver disease, whether it's decompensated cirrhosis, whether it's acute on chronic or severe alcoholic hepatitis, by changing our philosophy and implementing other strategies. And our approach was to take into consideration a multidisciplinary approach to this patient with integrated addiction team within our transplant program. We also implemented relapse prevention treatment, both pre, if possible, if not post-transplant, and we implemented biomarker surveillance. And I'm going to show you some of our results in that. First of all, the benefit of integrated addiction team is several-fold. First of all, it can allow us to identify the modifiable risk factor. It can improve access to alcohol use disorder treatment, more patient-centered, and therefore they buy into this, the patient. It helps to improve the communication and collaboration between the hepatologists and the mental health providers. And it also helps to find the earlier detection of return to drinking post-transplant with prompt intensification of the support, and also reduce the post-transplant alcohol use. So in what we do in Toronto as part of our assessment of our patients, they would see the hepatologist, but they also have a very in-depth psychosocial suitability for transplantation. We look at the severity of alcohol use disorder using the DSM-5 criteria. We take the history of relapse they had in the past. We look at the willingness of the patient to commit to abstinence and engage in AUD treatment before and after transplant. We look at their history of substance use and psychiatric disorder. We look at the adequate support network and stable housing, and we also do biomarker testing. Just to mention that alcohol use disorder does not apply to all the patients, and this is a psychiatric diagnosis, and not every patient with alcohol-related liver disease has AUD, and therefore they may not need this intensive treatment if they don't meet the criteria of AUD. And for example, in the first set of patients, that 300 patients that we assessed in our program, as you can see here, 15% meet the criteria of mild AUD, another 15 moderate, 50% had severe, but 15% of the patients had no criteria of AUD, and those are the patients that most likely they don't need any particular treatment or intervention post-transplant. In terms of the substance use and psychiatric disorder, this is particularly important because any active comorbid substance use disorder, except tobacco and cannabis, at least in Canada, is a contraindication, at least in our program, for transplanting patients, and they need to be of any other substance use. If they have any untreated refractory severe comorbid psychiatric disorder, that's very important, and that needs also be treated as part of the approach to this patient for transplantation. And these are, for example, anxiety and depression. And that's also indicate again that we need to have a multidisciplinary approach, because as a hepatologist, making the diagnosis of anxiety or any other underlying psychiatric disorder would be extremely difficult. And even if we are able to detect some degree of anxiety, prescribing the appropriate treatment to this patient requires a really involvement of the specialist. We do a biomarker testing systematically. We generally, in the past, in the first few years, started with urine ETG. Then we moved now to PET as more reliable detection of alcohol use disorder, alcohol consumption within a period of several months prior to consideration. And what I wanted to show on these slides is that when we started implementing the biomarker surveillance, we detected as high as 5% of the patients who were coming to our clinic to be assessed for liver transplantation, they had a positive ETG, and ETG detect alcohol within 5 days prior to consumption. So showing that, these patients, knowing that they are coming to the clinic, some of them were still drinking. And these are the patients that we could easily miss if we don't have these biomarkers implemented. And then in terms of treatment for AUD, relapse prevention treatment is a skill-based cognitive behavior treatment that we provide to all our patients. If they are not encephalopathic, we start those treatments while they are waiting for transplant. If not, the session starts after they have recovered and go home. And also we provide them with AUD pharmacological treatment if needed. And again, all this treatment is managed by our psych team. And similarly with the treatment of any comorbid psychiatric diagnosis. We have also a ALD committee where we meet once a week and we discuss suitability of the patient that have been evaluated by the team, by the multidisciplinary team. And if a patient is not suitable for transplant because they don't meet any of these criteria, we provide recommendation as what needs to be changed. And we send this recommendation to the referring physician. And we are open to take referral back for this patient. And this is a paper that we published recently where we reported the outcome of those patients, about 100 patients that were re-referred back after they have implemented what was recommended to them. And some of them are waiting for a transplant, and some have been now transplanted after accomplishing what was requested. So this is the result of the very first set of the patients that were transplanted as part of this holistic approach and integrated care. And I just want to show you on the red box that the rate of relapse to alcohol use in this series was around 7%. And when we compare them to the rate of alcohol relapse in the 5 years prior to starting this approach in our own program, the rate of relapse was 3 times less. Since this publication, we have increased our number. This was some of the numbers as of last year. I haven't updated the slides, but our rate of relapse is around 11% as of October last year. But what is very important to keep in mind is that of those 19 patients who returned to relapse, we were able to detect and engage them back in the AUD treatment, 15 out of those 19, so about 80% of those patients. And abstinence was able to be reestablished in this group in 84% of these patients. So 16 out of those 19 patients were cut back, and they are now abstinence. I also wanted to highlight a similar approach, and this is slides that I got from Dr. Bangi here that was presented last year at ILTS in the plenary session with their experience in Medanta with 130 patients who underwent liver transplant with alcohol-related liver disease with live donor liver transplantation, and they also show similarly excellent outcome post-transplant with 80% survival at 16 months post-transplantation. They had 15 relapse in their group, about 11%, and 2 of these 15 patients lost their graft, but also I understand that they have similarly a very thorough assessment in terms of relapse to alcohol prior to transplantation by addiction team. So in summary, outcome of liver transplant for alcohol definitively is excellent. The risk of relapse, however, remain high if there is not a robust post-transplant program that helps mitigate this risk. And I do really believe that integrated care and multidisciplinary approach is important to mitigate the risk of relapse to alcohol. And acknowledging our multidisciplinary team that helps assessing this patient and being involved as our part of the committee and our weekly meeting. And also wanted to invite you all to the ILTS annual meeting, which is next year in Singapore in May, and also to ILTS consensus meeting, which is on live donor safety and long-term outcome, which is going to be in Toronto in March 2025. Thank you so much.